Interpreting calcium and parathyroid hormone, what physicians are tend to know. Welcome, Dr. Kaushal Sheth.
So good morning, everyone. Thank you, APR and ESR for this wonderful opportunity. In next few minutes, we will discuss about the calcium PTH interaction. So first of all, what is metabolic bone disease? So basically, it is a disorder of bone mineralization. It is osteomalacia, which results from the calcium and phosphorus imbalance. And usually, this kind of patients present with the bone pains, pathological fractures, muscle weakness, or nephrocalcinosis. It is different from the osteoporosis, like it is a disease of volume and it is painless virtually until fracture occurs. So whenever patient present with the bony pain, it is osteomalacia and usually not the osteoporosis. Then why it is important for us to know? Because most of these conditions are diagnosed late, and by that time the disease has become debilitating for the patient. But complete cure is possible, and it is often life-changing for the patient. So basic physiology, there are 4 parathyroid glands as we know. It secretes PTH. PTH resorb the calcium from the bone and maintain the blood calcium level in the very narrow margin to maintain the neuromuscular function. Similarly, PTH also acts on the kidney to activate 1-alpha hydroxylase enzyme to activate vitamin D, which then again help in absorption of calcium and phosphorus from the gut. Also, PTH acts on the kidney to throw out the phosphorus. So basically, high PTH causes high calcium and low phosphorus. And this the most symptoms of this bone pains and everything is because of actually low phosphorus and not the high calcium. So basic evaluation of this metabolic bone disease starts with the calcium profile. The first tier of investigations are calcium, phosphorus, and creatinine. We should keep in mind that phosphorus should always be done in the fasting because carbohydrate-rich diet can lead to low phosphorus falsely. So it should be done in the fasting. The second tier investigation include the ALP, PTH, and vitamin D. So hypocalcemia is defined as a calcium less than 8.5 milligram per deciliter, and hypercalcemia defined as a 10.5 milligram per deciliter. For ionized calcium, we should consider respective laboratory range. So when should one order calcium profile? What are the indications of the calcium testing? So these are the summary of the various guidelines. So first and foremost, symptoms of hyper and hypocalcemia. Symptoms of hypercalcemia like thirst, polyuria, constipation, etc. And symptoms of hypocalcemia like paresthesia, cramps, tetany, seizure. Then second is fragility fractures. Third one is renal stone, pancreatitis, CKD, and chronic acid peptic symptoms. Guideline says that even one episode of renal stone warrants calcium evaluation because it is very cheap to do, very affordable investigation. And we can prevent the future comorbidities. The fourth one is proximal muscle weakness with bony pains. Before moving to advanced investigation, if we can check this calcium profile, then we can save the patient from the further comorbidities. Similarly, patient on the lithium therapy, because lithium can cause parathyroid mediated hypercalcemia. So at least every 6 months, patient is taking lithium for a long time. We should check the calcium level in such patient also. Then when to test for the PTH? PTH is second tier test. So most of the time not required in the first evaluation. But whenever we find the abnormality in the calcium profile, then definitely we should check for the PTH. Also in the patient of rickets or osteomalacia and CKD stage 3 onwards. Now, what is the most common cause of high PTH? It is vitamin D deficiency. And what is the most common cause of low PTH? It is the cold chain issue. So PTH is a heat labile hormone. We should ensure that it should be sent in a very maintained cold chain in a trusted laboratory because laboratory variations, especially in the peripheral labs, can often cause misdiagnosis. Now, group of the parathyroid disorders, basically they are hypoparathyroidism and hyperparathyroidism. So what is hypoparathyroidism? Simply, it is low PTH, low calcium. Basically, it is PTH deficiency. The most common cause is post-surgical. Any thyroid or parathyroid surgery can cause transient or permanent hypoparathyroidism. Other causes are autoimmune or infiltrative disorder like thalassemia or hemochromatosis. Then, on the other side, hyperparathyroidism can be divided into primary secondary and tertiary. Primary is high PTH, high calcium. And the causes would be adenoma or hyperplasia. It can be single or multiple. The secondary hyperparathyroidism is high PTH but low to normal calcium. And common causes is vitamin D deficiency or CKD. And tertiary hyperparathyroidism, when the secondary hyperparathyroidism of the CKD becomes autonomous, and then there is a occurrence of the hypercalcemia from normal calcium, then we call it tertiary hyperparathyroidism in the CKD. And then there is a one more interesting entity, which is pseudo hypoparathyroidism. It is pseudo hypo. That means the calcium is low, patient has frank symptoms of hypocalcemia, but PTH is high. Basically, it is PTH resistance. It is a mostly genetic condition. So how should we approach to the hypercalcemia patient? First step is measurement of the intact PTH. Nowadays, most of laboratory doing the intact PTH only. Then if PTH is high, then it is a PTH dependent hypercalcemia. And the most common cause is primary hyperparathyroidism. Sometimes if the urine calcium creatine ratio is low, then there is a possible entity called as FHH or familial hypercalcemic hypocalciuria. It is a benign entity, usually diagnosed very incidentally only, but that should be keep in mind when dealing with the mild form of primary hyperparathyroidism, because it does not require any active management. On the contrary, if PTH is low, then it is a PTH independent hypercalcemia. And the first step should be measurement of vitamin D level, because vitamin D toxicity, iatrogenic, is very common cause of the PTH independent hypercalcemia. If vitamin D level is normal, next we can measure is 125 dihydroxy vitamin D. It can be elevated in the kind of lymphoproliferative disorders or the granulomatous disorder. If both are normal, then in appropriate clinical settings, we can think of multiple myeloma or thyrotoxicosis. Thyrotoxicosis can also cause PTH independent hypercalcemia. And sometimes it happens that patient comes with a calcium report, and then by clinical symptoms, we diagnose hyperthyroidism. And with the treatment, it resolves on itself. And the last one is malignancy related hypercalcemia. Squamous cell carcinomas can cause hypercalcemia, and it is usually very severe, and the malignancies are evident. It is overt malignancies, nothing like occult malignancy. So these are the causes of the hypercalcemia. Now we see certain case example. So this is a case 1, a 60-year-old lady presented with bilateral lower ribs pain and thigh pain and ankle pain, and consulted rheumatologist for the same. Rheumatology workup was negative. So the calcium profile was done. Calcium was 8.5, PTH was 600, and vitamin D was 15. So here, low normal calcium, high PTH. It is a secondary hyperparathyroidism due to vitamin D deficiency. She was given vitamin D for 1 month. Within 1 month, she had dramatic improvement in the symptoms and proximal muscle weakness as well. And PTH came down from 600 to 66. So the point is that PTH can go as high as 600 in cases of vitamin D deficiency, and we should treat it first and then again reevaluate. Case 2, this 50-year-old lady came with a complaint of hip pain and difficulty in walking. She had this kind of limping gait since almost 1 year, and initially she took the nearby doctor consultation at Una, and then she consulted one of the orthopedic surgeon there, and then he finally advised CT scan. So CT scan, she was found to have this multiple lytic lesion, as we can see here also on the vertebra and the iliac bone. So she was suspected to have some kind of malignancy which is not detected, and these all lesions are suspected to be metastasis. So she was referred to an oncology center at Ahmedabad, and then they did the biopsy there. And biopsy was suggestive of osteoclastoma or simply brown tumor. And then unfortunately, calcium profile was ordered. The calcium was 12.7, phosphorus was low, 2.7, and PTH was 847. So it is high PTH, high calcium, so primary hyperparathyroidism, and the lesions were brown tumor. So after that, she was referred for the endocrine workup. Then localization was done via CT neck. It showed the right inferior parathyroid adenoma, which is the most common site of parathyroid lesion, and she was operated, and then she was cured. But because of this extensive lytic lesion, she went into hungry bone syndrome. Hungry bone syndrome is an excessive requirement of calcium and phosphorus in the post-op period. So these patients need high dose of calcium and active vitamin D, calcitriol, sometimes up to 1 year as well, because all the calcium we give, the bone will take up because bone is getting regenerated. So the point here is that multiple bonolitic lesion, of course, there can be multiple differential diagnosis, but to going for the further invasive investigations, we can simply do the calcium profile and get saved from the invasive investigations. But hyperparathyroidism is a spectrum of disorder. We see one of the severe presentation, but there can be a milder or even asymptomatic presentation. In the scenario of the multiple health checkups, sometimes the patient end up with just the high calcium. Until then, they didn't know that they have hyperparathyroidism. So similar one such case, a lady with a mild bilateral shoulder pain and pain in the feet, again consulted rheumatologist. There was no any history of major fracture or renal stone. Rheumatology workup was negative, but calcium was mildly elevated. On one instance 10.7 and another time 11.1. Annual calcium range was upper limit was 1.33, it was 1.44 here. So mildly elevated calcium level. Phosphorus was again mildly low only, below 3.5, and PTH was mildly elevated. So this forms the case of high calcium, high PTH. So it goes in the favor of mild primary hyperparathyroidism. But here in such cases we have to rule out FHH because it can be a benign entity, familial entity, and then she does not require surgery. So the urinary 24-hour urinary calcium was done. It was more than 400 milligram per 24 hours. So it is hypercalciuria. And we can also check for the 24-hour urinary calcium clearance ratio. It was 0.03. More than 0.01 is considered high. So she had hypercalciuria. So now it is not FHH. It has to be hyperparathyroidism. So next step, localization. But in such mild cases, sometimes the localization also becomes difficult because we have caught the disease early. So on NIBI scan, there was a very faint uptake in the lower pole of the right lobe, which was not very convincing. So CT scan was done for the CT. Initially, it also gave that negative report. There is nothing is found on the CT scan. Then it was reviewed again, and expert USG was done, and we corroborate all the findings, and then we decided. Hello. So it was decided that this might be the 9 millimeter adenoma and it was excised. Intra PTH fall down more than 50% to 32 picogram per ml. So that means that she is cured. She actually had hyperparathyroidism, and post-op she went into transient hypocalcemia, and within 1 month she was completely fine. But diagnosing hyperparathyroidism is not enough only, especially in the young patient. In young patient, if we diagnose hyperparathyroidism, we should look for the syndromic associations like MEN1 syndrome. MEN1 syndrome can have hyperprolactinemia, pituitary tumors, or pancreatic neuroendocrine tumor. And MEN2A syndrome can have medullary carcinoma of thyroid or pheochromocytoma. So guideline says that any patient with the below 30 years of age with hyperparathyroidism, they should undergo genetic testing because they can have hereditary hyperparathyroidism. Now, after parathyroid, calcium beyond parathyroid, that is PTH independent hypercalcemia. So here the 62-year-old diabetic lady without any symptoms incidentally found to have hypercalcemia. Calcium was 11, phosphorus was 5.5, and PTH was 3. It was checked twice, PTH was low. So it is a PTH independent hypercalcemia. The vitamin D was level checked next, it is more than 150. And on history, she had an injection erakitol intake, 1 ampule every week for the 3 weeks. We know such kind of patient come across. So this happens. It is a simple case of vitamin D toxicity. If patient is not very symptomatic, we can just leave them alone and they will be fine. If patient is symptomatic, then for a brief duration, we can give them short course of steroid. So the practice point here is we should be aware of the iatrogenic causes. And nowadays, various calcium combinations with calcitriol in that are pushed with calcium orotate, calcium aspartate, and everything. So they contain calcitriol, which is often overlooked. This calcitriol intake, inadvertent intake, can cause hypercalcemia, and routine supplement, there is no role of calcitriol. Calcitriol has to be used only in these conditions: hypoparathyroidism, vitamin D resistant rickets, CKD with high bone turnover, and hungry bone syndrome. Apart from this indication, there is no role of calcitriol as a routine supplement. So next case, 42-year-old gentleman, known case of hypertension and CKD. Baseline create was remaining around 1.4 to 1.6. Then he had a right-sided shoulder pain, so he took NSAIDs by himself, and within 1 month he developed AKI. Ended up with a creatinine of 5.3 milligram per deciliter. So he consulted a nephrologist. During workup, he found to have hypercalcemia. Calcium was 13.5. He was admitted, the fluid was given. Next day, the calcium profile was done. So calcium was 12.7, phosphorus was 4.7, not very low, not high, but create was 3.9. So we really interpret the phosphorus here. PTH was checked twice, it was 6.7. So high calcium, low PTH, it is a independent hypercalcemia again with high creatinine. So in such situation, of course, our first thought will be, is it multiple myeloma? So we tend to rule out this multiple myeloma because there is altered RFT, high calcium, low PTH. But SPEP was negative, hemoglobin was negative, and did not have any other chronic symptoms or symptoms like weight loss. So multiple myeloma was ruled out reasonably. So next what? Next workup was considered in the line of pH independent hypercalcemia. Vitamin D was done, it was 29, so it is normal. But 120 hydroxy vitamin D was 94. The upper limit is 54, so it was significantly high. And these patients, the drugs were checked thoroughly. There were no any history of calcitriol intake. So no history of calcitriol intake. So this 125 vitamin D is coming from somewhere. So it has to be either granulomatous disease or lymphoma. So next PET CT was done, FDG PET CT was done. It showed uptake in the various lymph node on both the side of the diaphragm, and impression they put was a probably lymphoproliferative disorder. Then the CT guided biopsy was done. Fortunately for the patient, it turned out to be the granulomatous disease and not the lymphoma. Possibilities put were tuberculosis or sarcoidosis. Serum H level was done. It was marginally elevated. In consultation with the pulmonologist, it was decided that we will treat in the line of sarcoidosis. If the symptoms worsen, then we might add AKT also, because sometimes it is difficult to differentiate on the basis of the biopsy. There were no any other investigation for the tuberculosis were positive. So coming to the management of the acute hypercalcemia in the hospital setting or ICU, the severe hypercalcemia is usually more than 14 milligram per deciliter, and malignancy-related hypercalcemia usually present with the acute hypercalcemia. Hypercalcemia causes volume depletion, and volume depletion further causes hypercalcemia. So this is a vicious cycle, keep going on until we treat the patient. So first and foremost step is the volume repletion. It should be 500 ml to 1 liter bolus, followed by 150 to 200 ml per hour. Our aim is to maintain the urine output in the range of 100 to 150 ml per hour. That is more important. And furosemide is not recommended by any guidelines, and it should not be used inadvertently unless there is AKI or heart failure. And even if we are using, then we should use it after sufficient volume repletion. Before that, otherwise it will aggravate the AKI. The other things we can use like calcitonin. Calcitonin, it is not very efficacious, but it is a very fast acting. So we use it for 2 to 3 days because of tachyphylaxis. Use as a bridging therapy. 4 to 8 units per kg every 6 hours we can give subcutaneously. It comes with 100 unit ampule, so we can calculate the dose and give 4 times a day. The mainstay of treatment is zoledronic acid. We can give 4 milligram. It should be given slowly or 45 minutes. But it is contraindicated if create is more than 4.5 milligram per deciliter. Up till then we can use, but with a reduced dose if create is high. The full effect comes of the zoledronic is 48 to 72 hours. So calcium will come down on second or third day. So that's why we need calcitonin for a brief duration. Denosumab can also be used, especially if the refractory hypercalcemia to zoledronate or severely impaired renal function. But denosumab is known to cause hypocalcemia. So on second, third, or fourth day, we should check if the patient is developing the hypocalcemia or not. Now, after completing the hypercalcemia, we are moving to the hypocalcemia. Calcium level below 8.5 is the hypocalcemia. We usually use albumin-corrected calcium level by Pine's formula, but recent large JAMA study showed that total calcium is also good enough to interpret the calcium level, and it usually corroborates well with the ionized calcium. Ionized calcium is a sensitive assay, and it should be done in a trusted laboratory. Otherwise, the values can be very confusing. So again, case of hypocalcemia, 55-year-old lady referred by the neurologist because she had a first episode of seizure, and then CT scan was showing the basal ganglia calcification. So this is a typical prototype case of hypoparathyroidism because calcium is 5.1, phosphorus is 7.8. So low calcium, high PTH. Low calcium, high phosphorus, and again low PTH. So it is a PTH deficiency or hypoparathyroidism. So here the patient will require calcitriol lifelong. She was treated with the calcium and rocaltrol, and other family members were also screened for the same. Now the interesting case, 30-year-old male, born of non-consanguineous marriage. He had certain developmental delay, intellectual subnormality. He also had on examination short stature, obesity, and relatively large head like this. So we can see that there is some syndromic kind of face is there. And at this young age, he has a history of cataract surgery 1 year back. And because for the seizures, he was evaluated by the neurologist, and he also had a basal ganglia calcification on the CT scan. Ionized calcium was very low, 0.72. The range is 1.13 to 1.33. So it is very low. PTH was high. It was not low here. Right? Phosphorus was high. I mentioned to forgot. So he had, TSH was 8.3. So he had subclinical hypothyroidism. PTH is high. Calcium is low. So possibility of PTH resistance. And he also had this short stature, obesity, relatively large head. So these are the features of the Albright hereditary osteodystrophy or AHO phenotype. So he suspected to have genus mutation. So we sent his genetics. It turned out to be positive. It was genus mutation, heterozygous. So this is a case of pseudo hypoparathyroidism. Again, he will also require lifelong calcium and calcitriol. Then the most common cause of hypoparathyroidism is the post-surgical. Here the lobectomy of the thyroid has a least risk, and radical neck dissection has the highest risk of the post-operative hypoparathyroidism. But with advanced techniques nowadays, for any kind of thyroid surgery, even for the carcinomas, ideally there should not be any post of hypoparathyroidism. In parathyroid surgery, we can have some transient hypoparathyroidism, and it is actually sign of the successful surgery. But after thyroid surgery, it is parathyroidism, so it should not be there. Now, management of the hypoparathyroidism. So what is our goal to maintain the calcium? In which range we want to have the calcium? Calcium should be maintained in the lower range. We usually aim for the 8 to 8.5 or sometimes 7.5 to 8 also, because we want to prevent long-term hypercalciuria and CKD. Otherwise, this patient can develop in later age CKD. And phosphorus is difficult to maintain sometimes in the lower range because phosphorus will be high. And if we give calcitriol, it will further increase phosphorus. So we advise the phosphorus restricted diet, and sometimes we need to give phosphate binder also in such patient to maintain the calcium phosphorus product in the less than 55 range. But sometimes there are difficult patients which cannot be controlled by the medication alone, and they may require PTH. But it is costly therapy and sometimes becomes impractical. But whenever there is a poor control of serum calcium despite the optimized medications, and oral calcium required is going above 2.5 gram, calcitriol requirement is going more than 1.5 microgram per day. Because if we give them this high dose, then they will develop hypercalciuria, nephrolithiasis, and CKD. So such patients are ideal candidate for the PTH injection as well for the hypoparathyroidism. So to summarize, calcium, phosphorus, alkaline phosphatase are very affordable set of investigation, and our threshold should be very low for the screening patients, like patient with the musculoskeletal complaints like pain with proximal muscle weakness or suspected fibromyalgia, renal stone, multiple nitric lesion of the bone. These all patients can have actually metabolic bone disease but presented with the various symptoms. So we should screen this first. Phosphorus should always be done in a fasting because carbohydrate can reduce the phosphorus level and we might think it is low. PTH to be sent in a cold chain in a trusted laboratory and sometimes need to be checked twice also. We should be aware of the iatrogenic causes. Parenteral vitamin D is required only in cases of the malabsorption, so inadvertent use should be stopped. And calcitriol use should be restricted. Whenever prescribing the calcium combination, we should be aware that there is no calcitriol in it. Hypercalcemia in the presence of the low PTH, not normal, sorry, low PTH. It is a PTH independent hypercalcemia, and here we should suspect vitamin D toxicity, malignancy, and granulomatous disorder. And in the treatment of the hypocalcemia, calcium should be maintained in the low normal range to prevent the hypercalciuria, and CKD. With that, I would end. Thank you. If any question.